Behcets disease is the topic of discussion for this video. Hello everyone, myself Dr. Maddineni Srinivas, dermatologist from Bharat. So let us begin the discussion without any further delay. We are going to cover mainly the mucocutaneous manifestations of Behcets disease. Apart from this, we are also going to see few other important points related to the history, how to diagnose this, what are the criteria to diagnose this, and what is the management strategy which we are going to use in the Behcets disease. So let us begin the discussion without any further delay. So yes, this was a theory question asked in the DNB examination December 2025 as a simple mucocutaneous manifestations of the Behcets disease. So points related to the history which you should know about Behcets disease. So this is basically a vasculitis which is going to involve all the sizes of the vessels. So it could be arteries and veins, and this is also called as Adamantiades-Behçet disease, and this can be defined as a chronic relapsing multi-system inflammatory disorder which is mainly characterized by involvement of three important areas. So what are those? The oral mucosa, genital mucosa, and also the eyes. So these are the three structures which you have to remember related to the Behcets disease. So coming to the historical timeline, so Hippocrates in the 5th century BC has actually described the triad of the involvement of the oral, genital, and also ocular involvement. And in the 1930, the ophthalmologist Benedictus Adamantiades has actually presented a case of relapsing iritis with hypopia on and oral genital ulcers in Athens. And in the 1937, the Turkish dermatologist Hulusi Behçet actually published a series of the patients displaying the triple symptom complex, and he attributed virus to be the etiological factor for this, and he is the person who introduced this triad of the symptoms as a particular disease. So that's why in the dermatological literature, to remember his name forever, the condition is given his name Behcet's disease, and commonly it is called as Behcet's disease, though it is also called as Adamantiades-Behcet disease. So coming to the epidemiology, you should remember that this condition is very prevalent in the populations living along the Silk Road. Ancient days there used to be the Silk Road along which trade used to happen, which is covering Mediterranean basin, Middle East to the East Asia and the Japan. And this condition is also called as Silk Road disease for the same reason, because it is very prevalent in the individuals who are there in this particular area. So this is the primary Silk Route which is depicted by this picture, right? And also you should remember there is a very high genetic association with HLA-B5 and also HLA-B51. So these are the two genes which are important. Coming to the Indian scenario, what is the significance of Behcet's disease in India? So you must remember that studies from the Indian territory tertiary care centers reveal a milder clinical phenotype with a little bit of female preponderance. And also you must remember the mean age is 27 years, 27 to 30 years, and primarily it is dominated by mucocutaneous as well as the joint involvement. Okay, so in the Silk Road areas, the condition, Silk Route areas, the condition could be very severe, but in the Indian population, the studies have revealed that it is going to be milder clinical phenotype, right? Coming to the etiopathogenesis, if you remember, Hulusi Behçet actually presented a case and he felt that virus was the etiological factor for Behcet's disease, right? So actually now, after so much of research, it was observed that the exact etiology is unknown, right? It is widely understood to represent a T helper 1 type of autoinflammatory and autoimmune response triggered by environmental agents. So these environmental agents could be so many things. So like for example in the bacteria Streptococcus or certain viral antigens, and also genetic predisposition HLA-B51, we have already seen this. So what is exactly happening in this condition, etiopathogenesis, is in the genetically predisposed host, that is HLA-B51 positive individuals, if there is an environmental trigger, if it is coming in contact with that individual like streptococcal infection or viral particles, so it is going to lead to the hyperactive innate and adaptive immune cascade, that is T helper 1, T helper 17 shift is going to be seen, and it is going to lead to the neutrophil activation, chemotaxis, more and more neutrophils, and degranulation. So all these are going to ultimately lead to the endothelial cell dysfunction and also microvascular thrombosis, which will lead to the clinical lesion. So ultimately there is going to be vasculitis, which will manifest clinically as aphthous ulcers, erythema nodosum, pustule formation, which are going to be sterile pustule without any organism, right, and retinal vasculitis. So these are all the manifestations clinically in a summary way, if you want to remember, because of the etiopathogenesis, which is initiating in a genetically predisposed individual with some unknown triggers, right. So now coming to the topic, clinical manifestations, especially in the mucosa and also in the skin, what are going to be the changes which we can see mucocutaneous manifestations. So mucocutaneous lesions are the hallmark of the Behçet's disease, occurring in almost 100% of the patients over the clinical course. So it is going to be very chronic condition, which sometimes could take a few years to be even diagnosed because of its rarity. The treating rheumatologist or ophthalmologist or dermatologist may not be actually able to diagnose the patient having the Behçet's disease, and they may be treating it for various other conditions. So diagnosing this condition is very important, for which you should be having a very clear cut idea about the mucocutaneous manifestations of this condition, and that is the reason why this is being asked as a theory question, right. Okay, and this mucocutaneous manifestations are the presenting feature in the patients most of the time. That is the reason why you should be having a clear cut idea. So what is the most important finding which you are going to see? That is the recurrent aphthous ulcers, oral ulcers. It is going to be seen in 100% of the cases, right, and it is the initial symptom in almost 65 to 70% of the patients. Coming to the morphology, you can remember the morphology of the lesions of the oral ulcers is going to be almost same like aphthous ulcers. You cannot even differentiate between the aphthous ulcers which are seen routinely and the aphthous ulcers seen in the Behçet's disease, right. So they are going to begin as erythematous papule or macule, which rapidly necrotize to form the painful punched out ulcer, and the ulcer bed is covered by yellowish white pseudo membrane, just like in the aphthous ulcers, and it is also surrounded by prominent erythematous halo. Everything is same like aphthous ulcer, and the distribution is, remember, it can involve any part of the oral cavity: buccal mucosa, tongue, soft and hard palate, uvula, gingiva. But interestingly, it is going to spare the lips. So that is one point to remember, and this might also help to differentiate between the viral infection herpes labialis, which could also produce recurrent vesicular lesions, which can heal with the polycyclic margined multiple ulcers, right. So because lips, and also you can see the perioral area also is going to be affected in the herpes labialis, whereas in Behçet's disease it is going to involve the mucosa, right. That is one differentiating point. So coming to the evolution, clinically they are indistinguishable from the recurrent aphthous stomatitis, and they heal within 1 to 3 weeks time, typically without leaving any scars. So this is the classical manifestation of the oral ulcers in Behçet's disease, right. Now coming to the genital aphthous ulcers. So same aphthous ulcers will also be seen in the genitalia. In up to 90 to 93% of the patients, this could be the presenting manifestation of the Behçet's disease. Coming to the morphology, it is similar in appearance to the oral ulcers, but now some small differences are there. The genital ulcers are going to be larger, deeper, and they are going to be healing with very bad scar formation. So if a patient is having oral ulcers and also genital ulcers, in the genitalia there is going to be scarring, but in the oral mucosa, despite this condition being recurrent and chronic, there will not be any scar formation in the oral mucosa. So that is one important difference. And the presence of these depigmented atrophic genital scars are highly specific diagnostic indicator for Behçet's disease. So this is a very good pointer that the patient may be having a Behçet's disease. So coming to the anatomical distribution, what are the differences between males and the females in the distribution? In the men, the aphthous ulcers in the genitalia are going to be very characteristically located over the scrotum, very important, and also it is most common site, and the lesions are, the ulcers are going to be very painful, and the shaft of the penis may also be present in the ulcers. In the woman, the ulcers are going to favor the vulva, the labia majora and minora, and also vagina and cervix may also have the ulcers. Perianal aphthouses could also be a presentation, and you need to have in your mind that possibly a very important differential which you need to think is Crohn's disease, right. So, coming to the differences between the oral ulcers and the genital ulcers, we have already seen that. We are just going to summarize as a table form. So, oral ulcers 100%, genital ulcers 90-93% of the patients. Oral ulcers are smaller, whereas the genital ulcers are larger, deeper, and more destructive and very painful, and they are going to leave behind very bad scars, right. Okay, that is an important difference, and also the genital ulcer highly specific diagnostic pointer when compared to the oral ulcers, because oral aphthous ulcers clinically you cannot distinguish from the recurrent aphthous stomatitis. Coming to the cutaneous manifestation. So, skin lesions of Behçet disease represent a spectrum of inflammatory and also vasculitic patterns. So, first one we are going to see the erythema nodosum like lesions, which can be present in 60-62% of the patients, and it is most commonly seen in the females. So, how does erythema nodosum present? It is going to present as erythematous tender nodules over the shin, and it is going to be painful, obviously tender, and it is going to be in the lower extremities, and it is going to heal with pigmentation. So, post inflammatory hyperpigmentation can be seen, and it is not going to ulcerate. Okay, there will not be any ulcer formation in the erythema nodosum lesions associated with Behçet disease. Next cutaneous lesions are papulopustular and acneiform lesions. So, acne like lesions can be seen in 30-30% or 31%. In the males this is commonly seen. So, erythema nodosum like lesions common in the females, and acne like lesions are common in the males. Clinical features are going to be, they are going to be sterile papulopustules on an erythematous base and also indistinguishable from acne vulgaris. These lesions cannot be differentiated from the lesions which you see in acne vulgaris. But the clinical, the unique point related to this condition is that they are going to develop in non-seborrheic areas such as the extremities, trunk, and the buttocks. So, these sites are going to be very interesting, the extremities and also the buttocks. Acne lesions usually do not occur, these are non-seborrheic areas, but if you happen to see these acne form lesions in a patient having the recurrent oral ulcers and the genital ulcers and erythema nodosum, then think of Behçet disease as a possibility. Apart from this, there are some very small group of patients we can see some lesions which are going to the superficial migratory thrombophlebitis. So, you know that Behçet disease can involve the arteries and veins, that is the blood vessels of all the sizes. So, it can also affect the veins, leading to this painful linear erythematous subcutaneous cords primarily on the lower limbs, and this is a critical cutaneous marker as it correlates with the DVT, deep vein thrombosis, and systemic large vessel venous disease. There could also be PG like ulcers, pyoderma granulosum like ulcers can also occur in these patients. So, what is the classical feature of the PG like ulcers? So, the ulcer is going to be rapidly progressive, painful ulcer which will have undermined edges and a violaceous border. So, that is a classical point related to the pyoderma gangrenosum like ulcers. Remember, pyoderma gangrenosum is a misnomer because it is not having any infection associated with this, but still because ulcer is looking like some infectious process, it was named like this. Okay. So, now just to summarize what are all the mucocutaneous manifestations. So, in the skin we have this erythema nodosum like lesions, papulopustular lesions which are going to be sterile pustules, migratory thrombophlebitis, and the PG like ulcerations, right. Now, coming to the some bedside test, pathology test, I hope you have heard of this test, which is basically exaggerated non-specific cutaneous tissue hyperreactivity to the minor mechanical trauma which is produced as a part of the test, right. and it is one of the bedside markers for the diagnosis of the Behçet's disease. This what are we going to do is basically with a 20 gauge sterile disposable needle, we are going to prick the skin at 45 degrees angle and up to a depth of 3 to 5 millimeters. And so then what will happen, we have to observe, we have to call the patient back after 1 or 2 days, and what we are going to observe at the site of the prick, we are going to say erythematous papule or a sterile pustule is being formed, and if it is going to be seen, then we are going to call it as a pathology test positive. And what is the significance, importance of this test being positive is, remember it is highly variable globally. This test results are going to be very variable depending upon the area globally. Very high in Mediterranean or Middle Eastern countries, that is if a patient is having this pathology test positive in this particular area, then the sensitivity of this test is very high. Up to 60 to 80% of the times the patient may be having the Behçet disease, but significantly it is lower in the western countries and in India. Simple reason, because this is non-specific test, it is not specific for the Behçet disease. So, it could be 30% possible that the patient may be having Behçet disease if he is from the western countries and in the India. Okay. Coming to the histopathology of a positive pathology reaction, if you do a biopsy from the pathology test and if you see, what are going to see, you are going to see the neutrophil rich inflammatory response. Okay. So, basically there is going to be leukocytoclastic vasculitis. Coming to the criteria, diagnostic and classification criteria, because there is no definitive pathognomonic laboratory test for the Behçet disease, diagnosis relies on the clinical point system base, that is what are all the important changes which are seeing in the mucosa and in the skin. Based upon that, we are going to diagnose whether the patient is having Behçet disease or we are going to rule it out. So, there was this international study group criteria in the 1990 which was put to diagnose this Behçet disease, and now recently 2014 there is this international criteria for Behçet disease, ICBD. So, there are very important differences which actually happened in these two. So, in the 1990 it was thought that recurrent oral ulcerations at least for 3 times in a 1 year span is going to be mandatory criteria to diagnose Behçet disease. This was mandatory criteria, and other than that, any of these two, that is recurrent genital ulcers, typical eye involvement, uveitis, especially the posterior part of the eye involvement, the retinal and uveal involvement, and also cutaneous lesions, erythema nodosum like lesions, and also pustules and positive pathology test. So, any of these two along with the mandatory oral ulceration, if it is present, then that patient was considered as a Behçet disease. Criteria for a Behçet disease 2014, the points are going to be given to the individual manifestation. So, oral ulcers here in this, according to this criteria, are not mandatory, but they are going to carry very high point value. So, 2 points are going to be given if there are oral ulcers, genital ulcers or ocular lesions, and 1 point is going to be given for the skin lesions, vascular lesions, that is thrombosis, neurological manifestations and positive pathology. So, this is the table which is going to summarize that, and a cumulative score of 4 points if at all patient is having, then yes, we are going to consider it as a Behçet's patient. Coming to some extra genital and extra cutaneous systemic manifestations, primarily Behçet disease is mucocutaneous and ocular disease, but there could be systemic involvement. So, the ophthalmological manifestation, the ocular disease, 90% of the cases are going to have this, especially the posterior part of the eye is going to be affected, posterior uveitis will be there, retinal vasculitis which can lead to the irreversible blindness if it is not treated. That is why diagnosis of Behçet disease is very crucial. If we cannot diagnose this, or if we delay in the diagnosis of this Behçet disease, then it is going to lead to catastrophic complications. Anterior uveitis with hypopyon can also be presenting feature. And in the joints, there could be non-erosive asymmetric limiting oligoarthritis, especially affecting the major joints. and it could also be affecting the blood vessels. Obviously it is a vasculitis, so there could be venous thrombosis, and also especially pulmonary artery aneurysm can also be one very important severe manifestation of Behçet disease. In the GI system, there could be discrete deep punched out mucosal ulcers in the ileocecal region carrying high risk of intestinal hemorrhage and perforation. And in the CNS, you have to remember meningoencephalitis is a possibility, and dural sinus thrombosis, and also cranial palsy could also be one manifestation. So coming to the treatment of Behçet disease, it is going to be tailored for the patient depending upon the severity of the involvement in the particular patient. So it is going to change from case to case, and also depending upon the organ involvement. In India, the disease is predominantly mucocutaneous and joint based, and it's going to be, the treatment is going to mainly conservative, and safe therapeutic regimens are highly encouraged. So what is that we are going to make use in the mucocutaneous lesions? Topical mild to localized skin involvement if it is the topical steroids, and also topical tacrolimus can be used in the patients. But remember, in the Behçet disease, the gold standard first line treatment is with colchicine 0.5 mg to 1.5 mg once daily. It is highly effective, and also it is very safe with long term control of recurrent oral genital ulcers, and also joint pains, and also erythema nodosum like lesions will also be under control. As a second line systemic agent, we can also use dapsone and pentoxifillin. So dapsone 100 mg and pentoxifillin 400 mg thrice daily are the dosages. Systemic steroids, oral prednisolone can also be used 0.5 to 1 mg per kg per day dosage. In the patients who are having acute severe mucocutaneous flares, remember, we cannot use the steroids for long term. It's only to take care of the sudden flares. And apremilast is FDA approved specifically for oral ulcers in the Behçet disease. So this point you have to remember. It is a phosphodiesterase 4 inhibitor which is used in the dosage of 30 milligrams BD. Apart from this, we can also use the, because tumor necrosis factor alpha is also a very important part in the pathogenesis of Behçet disease. So anti-TNF agents, adalimumab, infliximab can also be used, and also JAK inhibitor tofacitinib is also being used of late. So this is about the Behçet disease. I hope this video was helpful. If so, please do hit that like button, and also do subscribe if you are not yet subscribed. If you have any doubts, you can ask me in the comment section, and also you can hype this video if you are watching this within 3 days of releasing this. And I hope your doubts are clarified regarding Behçet disease. If you are having any more doubts related to any other dermatological conditions, you can put them in the comment section. So we'll meet again in the next video soon. Happy learning. Bye bye.